Today we'll be discussing an update on biomarkers in immuno-oncology. I'm Robert Anders, an associate professor of pathology and co-director of the Tumor Immunology Microenvironment Center here at Johns Hopkins.
And my name is Dariel Baiji. I'm a staff pathologist at Ameripath, Indianapolis. Today we're going to be talking about PD-L1 testing in different types of cancer, the expanded role of microsatellite instability and mismatched repair protein status in multiple cancers, tumor mutational burden as an evolving immuno-oncology biomarker, the relationship between tumor mutational burden and PD-L1, also expanding the use of checkpoint inhibitors to treat different cancer types, and wrapping up with the biomarker landscape. So to get started with PD-L1 testing in different cancer types, Dr. Andrews?
The PD-1, PD-L1 pathway inhibits the immune system. In an immune reaction, such as in a viral infection, the immune system is stimulated to produce cytotoxic T cells that kill virally infected cells. Once eliminated, the immune system is turned off. PD-L1 is one of the molecules that's responsible for turning off the immune response. Cancer cells exploit the inhibitory PD-1-L1 system to prevent the immune system from removing malignant cells in a patient. The PD-1-L1 pathway is inactivated by infusing a drug that binds to the PD-1 or PD-L1 protein and inactivates the inhibitory signal. The drug is an antibody that blocks the inhibitor, ultimately leading to immune stimulation. PD-1-L1 is not the only immune inhibitor, but it is the one that is currently most widely targeted. At the immune synapse, an antigen-presenting cell and T cell interact with go and stop signals. CTLA-4 and PD-L1 are the first and second stop signal or immune checkpoint proteins to be targeted in cancer patients. The results of these trials has revolutionized cancer therapy over the last decade. Predictive biomarkers indicate the likelihood a patient will respond to specific therapy. Predictive biomarkers are nothing new to pathology. For instance, HER2/neu is an oncogenic protein expressed in some breast and gastric cancers. A patient sample is stained for HER2/neu protein, and if the sample expresses sufficient amount of the protein, such as in the example here, the patient is eligible for treatment with a drug to block the HER2/neu pathway. PD-L1 is also a predictive biomarker. If a patient sample expresses PD-L1, such as in this example, there is about a 50% chance the patient will respond to anti-PD-1 therapy. Even if a tumor does not express the PD-L1 protein, there is still a chance, about 20%, that the patient will respond to anti-PD-1 therapy, leading to debate as to whether PD-L1 has a high positive predictive value. Oncologists typically find biomarkers with a high negative predictive value to be the most useful because if they are 100% certain that a patient will not respond to a specific therapy, they will select a different therapy. Given that these immune-modulating treatments can result in long-term cancer control, however, some patients and oncologists are willing to opt for treatment regardless of the test result, knowing there is the possibility of a long-term benefit to the patient.
The FDA has classified predictive biomarker tests into both companion and complementary diagnostic tests. This slide is important because the terms companion and complementary are sometimes used interchangeably, and that is incorrect. A companion diagnostic test is used in conjunction with a therapeutic drug to determine its applicability to a specific person. This test result must be positive in order for the patient to receive the drug. A complementary diagnostic test, on the other hand, identifies patients who respond particularly well to a drug, but it is not a prerequisite for receiving the drug. So unlike companion diagnostic tests, a patient may receive the drug regardless of the complementary test result. Depending on tumor type, PD-L1 immunohistochemistry can be both a companion and a complementary diagnostic test. The evaluation of PD-L1 immunohistochemistry is not straightforward because PD-L1 can be expressed on histiocytes, inflammatory cells such as lymphocytes, and malignant tumor cells. Additionally, PD-L1 can also be found on both the cell membrane surface or in the cytoplasm. The number of cells expressing PD-L1 reported as a percentage of stained cells is a critical determination. The percentage of PD-L1 staining cells is reported from 0 to 100%, and the cutoff for what constitutes a positive or negative test result varies by both tumor type and by which antibody is used to test the sample. There are currently 3 different PD-L1 scoring systems, each represented in this slide. To calculate the tumor proportion score, the numerator represents positively staining tumor cells divided by the number of all tumor cells in the sample. For the combined positive score, or the CPS, the numerator represents positively staining tumor cells and immune cells divided by the number of tumor cells in the sample. The third scoring system evaluates just the immune cells, with the number of positively staining immune cells being divided by the number of all immune cells in the sample. And we're going to look at some examples of this. The tumor proportion score, or TPS, in this example would be 50% because 2 of the 4 tumor cells stain for PD-L1. Here we have an example of a squamous lung cancer with a tumor proportion score of 100% because all tumor cells show membranous PD-L1 reactivity. In this example of metastatic lung adenocarcinoma, about half the tumor cells show surface PD-L1 expression, rendering a tumor proportion score of 50%. This example of metastatic lung adenocarcinoma shows no PDL expression whatsoever, with a tumor proportion score of 0. The combined positive score, as we said earlier, is a result of how many tumor and inflammatory cells express PD-L1 divided by the overall number of tumor cells in the material. In this example, if 3 tumor and immune cells express PD-L1 and there are 4 total tumor cells in the sample, the CPS would be 75%. This example of gastric carcinoma has a combined positive score of 20%, as some tumor and inflammatory cells are showing either surface or cytoplasmic expression of PD-L1. The immune cell score, once again, addresses only the proportion of immune cells with PD-L1 expression. In this example, if 2 of 4 immune cells are staining, the immune cell score would be 50%. This example of urothelial carcinoma has an immune cell score of 10%, as we disregard the tumor cells entirely and only evaluate staining in the immune cell compartment. Given the subjective nature of these scores, interpretation of PD-L1 staining can have high inter-observer variability, raising concerns about the reproducibility of test results. A recent large multi-institutional study involving 13 pathologists from 7 academic sites was undertaken to assess this. 4 PD-L1 assays were compared, 3 of which were FDA-approved and 1 was a lab-derived test. The pathologist then independently evaluated both the tumor proportional score and the immune cell score in 90 PD-L1 stained lung cancer samples. The intra-class correlation coefficient, or ICC, was calculated, which is a statistical test that measures how consistently the pathologists agreed with each other using these subjective scoring methods. As we see here, the ICC, or level of agreement between pathologists when assessing tumor proportion score, was excellent, averaging about 86%. For immune cell scoring, however, the level of agreement was unacceptably low at about 20%. It should be noted that there was no formal training for the participating pathologists in this study. The type of antibody used for PD-L1 immunohistochemistry adds another layer of complexity to interpretation. In this example, a urothelial carcinoma was stained using 2 different FDA-approved companion PD-L1 antibodies. Lab A, on the left, used one type of antibody, and Lab B, on the right, used another type. And as you see on the left, positivity is restricted mainly to the immune cells, with an immune score of 20%, while on the right, both tumor and immune cells show PD-L1 expression, with a combined positive score of 40%. In order for the immune score to be considered positive, at least 5% of the cells have to show PD-L1 staining, And for the combined positive score, at least 10% of the cells have to be positive. So using either antibody, in this specific example, the patient would qualify for anti-PD-L1 therapy. In practice, however, discrepant results often occur, such as when the immune cell score may not reach the required cutoff to be considered positive, while the combined positive score does, or where different immunohistochemical antibodies render different results on the same tumor sample. Given the many variables involved in PD-L1 testing, this clearly represents a new challenge for pathologists. We have to consider which of the various FDA-approved or lab-derived PD-L1 antibodies is used, which staining pattern we're going to interpret on any given sample, either the tumor proportion score, the combined positive score, or the immune cell score, which cutoff value is considered positive for various tumor types, which of the patient's tumor samples we should stain, such as the primary biopsy or the post-treatment resection or a metastatic lesion, and even which pathologist interpreted the stain, considering the varying levels of agreement amongst ourselves. In summary, PD-L1 testing is clearly more complicated than many other companion tests and likely represents the most challenging interpretive test that pathologists have ever faced.
And that brings us to our first case presentation, a 48-year-old patient with metastatic gastric cancer. In order to make treatment decisions, the oncologist requests microsatellite instability, or MSI status, as well as PD-L1 testing. To provide some context, there are about 25,000 new cases of gastric cancer diagnosed in the U.S. and nearly 1 million cases worldwide each year. Given that only 4% of affected patients will be alive in 5 years, there is urgent need for an effective therapy. A recent clinical trial involving 259 patients from 16 countries and spanning 15 months showed that patients previously treated with 2 or more lines of chemotherapy, followed by anti-PD-1, PD-L1 therapy, had an 11.6% objective response rate. This response rate, while not remarkably high, was among the first signs of a new treatment for gastric cancer and led to the approval of anti-PD-1, L1 therapy for this aggressive disease. Another important finding from this study was a near doubling of the response rate in patients whose tumors express PD-L1. Of the 42% of patients whose tumors lacked PD-L1 expression, there was only a 6.4% overall response to anti-PD-L1 therapy, while the 58% of patients with PD-L1 expression showed a 15.5% overall response rate. This indicated that PD-L1 can be used as a predictive biomarker and led to the FDA approval of PD-L1 immunohistochemistry with a greater than 1% cutoff as a companion diagnostic test. So returning to our case, PCR testing to evaluate MSI status showed that all 5 microsatellites are intact. And here we see the PD-L1 immunohistochemistry on the right. Given the tumor proportion score of greater than 1%, the patient is now a candidate for anti-PD-L1 therapy and has about a 15% chance of responding to the treatment. So PD-L1, what we know right now. PD-1, PD-L1 pathway is a targetable immune inhibitory system. It offers improved response rates in patients with aggressive cancers. It is an imperfect but useful predictive biomarker. Immunohistochemistry for PD-L1 is both a companion and a complementary test, and IHC interpretation is fraught with variables. So let's look at the expanded role of MSI and MMR testing in multiple cancers. The test for MSI and MMR consists of 1, microsatellite testing using DNA and is performed by polymerase chain reaction. 2, mismatch repair proteins are detected using immunohistochemical stains. And third, next-generation sequencing is an emerging DNA-based test. We are seeing more requests for MSI and MMR protein testing because of this study. In this study, they enrolled 86 patients in a 3-year period. The entry criteria was an advanced cancer that failed standard of care treatment and was established to be MSI high or mismatch repair deficient. 12 types of cancers were treated. The cancers range from bile duct to pancreatic, bone, and prostate. The waterfall plot shows the growth or shrinkage of the tumor at 20 weeks and at the best response time point. As you can see, nearly all the patients had a decrease in the size of the tumor, as indicated by bars below the x-axis. The overall response rate was a remarkable 53%, and a complete response rate, meaning there was no evidence of cancer in the patient, of 21%. Given the remarkable results of this study, the FDA approved this checkpoint inhibitor for the treatment of MSI high cancers. This was unusual since the FDA had never approved a single treatment for different cancer types. Traditionally, anti-cancer treatments are approved for a specific type of cancer, such as breast or lung. The key to this approval was the understanding of the common molecular mechanism, a defect in DNA repair systems. The treatment seemed to benefit cancers with the same molecular defect. It was not relevant that the cancer developed in different organs.
Which brings us to a case presentation that illustrates this testing. A 70-year-old patient with metastatic prostate cancer, which on biopsy was high grade and a Gleason pattern of 5+4, and also showed prominent tumor infiltrating lymphocytes. The treating oncologist requests MSI testing in order to make treatment decisions. As we prepare to send the patient sample for MSI testing, it's important to remember that PCR testing for MSI status, while effective in colorectal and endometrial cancers, has not been systematically examined in the 10 other cancer types that are now FDA-approved for anti-PD-1 therapy. In a recent study of 29 mismatch repair deficient prostate cancers and 26 mismatch repair intact prostate cancers, 27% of tumors showed false negative results by standard 5-marker PCR for MSI status. A modified approach using next-generation sequencing of 18 markers reduced the false negative rate to 3%. As requests for MSI status increase, we need to be mindful of the limitations of these tests and how different testing methods can render different results. So to summarize about microsatellite instability and mismatch repair testing, what do we know right now? Right now, oncologists are requesting this testing for many different tumors, not just colorectal and endometrial cancer. Important to keep in mind that neither PCR nor next-generation sequencing is FDA-approved for this testing, and next-generation sequencing is not widely available. Tumor mutational burden is an evolving immuno-oncology biomarker. Tumor mutational burden, or TMB, as the name would suggest, refers to the number of DNA mutations in a cancer cell. In order to determine this, we sequence the DNA of all the coding regions, or exons, of the entire genome. The calculated value is reported as the number of mutations per megabase, and most observers consider more than 10 mutations per megabase to be quote-unquote high TMB for a given tumor.
A DNA mutation is a change in one of the 4 bases, adenine, guanine, cytosine, or thymine, represented by the letters A, G, C, and T. In the top row, the lack of mutations results in the original or wild-type sequence. In the second example, a silent point mutation changes an individual base from adenine to guanine, but does not change the amino acid sequence. In this case, the GGA codon codes for the amino acid glycine, and so does the mutated codon GGG. This is called a synonymous mutation. In the third row, a missense point mutation results in a change in amino acid. The guanine to thymine transversion alters the resultant amino acid from glycine to valine. The nonsense mutation below also results in a change in amino acid sequence, stopping transcription entirely and resulting in a truncated protein. Other types of mutations, such as insertions, deletions, etc., are also likely to result in a dramatic change in amino acid sequence. For the purposes of TMB, the definition of mutation type is simply synonymous mutations, which don't alter the amino acid sequence, and non-synonymous mutations, which do alter the sequence. However, as we will explore this further, we currently lack a uniform definition of what defines TMB. The human genome contains about 180,000 exons consisting of 30 million bases. Whole exome sequencing evaluates all of these bases in all the exons or coding regions of the entire genome. In this example, all exons were sequenced and 6 mutations were identified. A gene panel approach sequences only portions of exons to reduce the cost of testing and the amount of data generated. In this example, a panel approach evaluated half the exons in the genome and discovered 3 mutations. We can assume that the other unexamined half of the genome has a similar mutational rate, so doubling the result also gets us to 6 mutations in total. So TMB testing can be done by whole exome sequencing. It's considered the gold standard. However, it's expensive and generates large amounts of data and requires more DNA from the patient's tumor sample. For targeted panels, there's uncertainty about minimum necessary coverage. It has a reduced cost and generates less data and is more easily integrated into hospital labs. And it has the advantage of requiring less DNA from the patient's tumor sample. The problem with TMB is the lack of standard definition and methods between labs. To address this concern, Friends of Cancer Research is an effort to harmonize across labs. Multi-stakeholders at the government, academic, diagnostic, pharmaceutical, and operational industry have come together to unify TMB. The timeline indicated below shows us that efforts are already underway, and we can anticipate a preliminary report in the summer of 2019. This effort aims to define and recommend testing methods, as well as establish analytical standards and standard procedures for labs wishing to set up this new assay.
So how does TMB apply to immune-based cancer therapy? This graph demonstrates the relationship between the number of mutations in a given cancer type and response to immune therapy. The y-axis represents increasing mutational burden, with a red line indicating averages for each tumor type. The cancers on the far right, with the highest mutational burdens, are more likely to respond to immune-based therapy.
In this graph, Yarchin and colleagues aggregated data from multiple clinical trials in which cancer patients were treated with anti-PD-1/L1 blockade. The x-axis along the bottom indicates the level of tumor mutational burden, and the y-axis represents increasing response to anti-PD-L1 therapy. The size of each circle represents the number of patients in each study, and the shade of blue in each circle indicates the number of tumors analyzed for each cancer type. Here, we clearly see a direct correlation between response rates and TMB, in that cancers with higher TMB are more likely to respond to anti-PD-1/L1 therapy than cancers with low TMB. So why does tumor mutational burden influence immune response? Possible underlying mechanism is illustrated here. If a tumor has 1,200 mutations, perhaps 770 of those may be non-synonymous, resulting in a change in amino acid sequence. About 340, 40% of those changes will result in amino acid sequences that do not occur elsewhere in the genome, resulting in 340 new antigens that the human immune system has never previously encountered. Computer algorithms suggest that about 120 of those neoantigens may be recognizable to the immune system, with an estimated 10% chance of stimulating anti-tumor immune responses. While these numbers don't sound very promising, keep in mind that perhaps even one high-quality new antigen recognized by the immune system may be sufficient to eliminate a patient's cancer. Some early evidence from clinical trials shows promising benefits. In this study, 34 patients with non-small cell lung cancer treated with anti-PD-1 therapy underwent whole exome sequencing. An initial learning cohort and subsequent validation cohort demonstrated that patients with durable clinical benefit had a significantly higher TMB compared to those who did not show benefit. Patients with a higher TMB also showed improved progression-free survival. This study was one of the earliest demonstrations of TMB being a predictive biomarker in immuno-oncology. More evidence of TMB correlating with clinical benefit. In this study, patients with stage 4 lung cancer that had not been treated with previous chemotherapy and had at least 1% expression of PD-L1 were enrolled to compare the response to chemotherapy versus combined anti-CTLA-4 and anti-PD-1 immune therapy. Among patients with high TMB, progression-free survival was significantly longer in the immune therapy group compared to patients receiving standard chemotherapy. This benefit was seen regardless of PD-L1 expression level and validates the role of TMB as a predictive biomarker for patients with lung cancer. In another study of 423 patients with lung cancer and greater than 5% PD-L1 expression, Carbone and colleagues found no difference in disease progression between the group receiving standard platinum-based chemotherapy and the group receiving anti-PD-1 therapy. However, when they retrospectively selected patients with TMB, the benefit of anti-PD-1 therapy emerged, as we see in the improved progression-free survival on the right. Careful examination of the supplementary data in this study reveal another interesting but somewhat disappointing finding. Anti-PD-1 treatment does not show a difference in overall survival compared to standard chemotherapy, even when stratified by TMB. As this study and others have now shown, TMB is a biomarker that influences relatively short progression-free survival, typically over weeks, but may not be a durable marker of overall benefit. Additional trials are currently underway to further elaborate the relationship between TMB and overall survival.
What do we know right now about tumor mutational burden? We know that TMB comprises a mechanism driving anti-cancer immune elimination, but the testing, however, for the level of TMB requires standardization. While TMB can predict progression-free survival in certain subsets of patients with certain types of cancer, TMB may not predict overall survival, and further studies are required to define clinical benefit. Which brings us to a case presentation to illustrate this point. A 57-year-old patient and former smoker presents with a 4.5 centimeter lung mass on CT scan. Pathology showed adenocarcinoma with pleural involvement and a positive lymph node with metastatic disease. Clinically, the patient is stage 4 and pathologically T2B N1 M1A. This necessitated an oncologic referral. The anticipated pathologic testing of this material includes mutational analysis with EGFR, ALK, ROS1, and BRAF, as well as PD-L1 immunohistochemistry, and possibly tumor mutational burden. The role of EGFR mutations in non-small cell lung cancer has been evaluated by various studies, and the results presented in the first chart show that EGFR-mutated tumors are associated with increased progression-free survival when treated with standard chemotherapy compared to anti-PD-1 therapy. The study at the bottom demonstrated a similar trend, but note that the statistical significance of these findings in both studies is questionable. Whether patients with EGFR-mutated lung cancer should be receiving anti-PD-1 therapy is still unclear. The test results for our case showed that there were no mutations in BRAF, EGFR, ALK, or ROS1. PD-L1 immunohistochemistry, as pictured here, showed a 90% tumor proportional score, and the tumor mutational burden was 18 mutations per megabase. The question, of course, from oncology being, is this patient a candidate for anti-PD-1 L1 blockade? And based on that tumor proportional score, the answer is absolutely yes. PD-L1 expression is a companion test, and a negative result would have rendered the patient ineligible for one PD-1 inhibitory drug. However, PD-L1 is also a complementary test for different anti-PD-1 drugs. In a patient with good performance status and no history of autoimmune disease and a relatively high TMB, the patient would likely be considered for checkpoint inhibitor therapy. Even though TMB has not yet been approved by the FDA, it may still sway an oncologist to treat a patient, knowing that even PD-L1 negative patients have a 20% chance of responding to checkpoint inhibitor therapy. So in terms of tumor mutational burden, there's a lot we still don't know. For example, the definition of what actually is the tumor mutational burden. Which cutoffs do we use to decide if a patient has high or low TMB? We don't know yet how and when to test. Validation is still required for most testing methods, and we don't know which specimens would be ideal. The role of TMB in the presence of other established biomarkers, such as EGFR, is also unclear, and the question of whether TMB and PD-L1 comprise independent complementary biomarkers also requires further study.
Which brings us to the relationship between TMB and PD-L1. Investigators have explored this question by examining molecular features that correlate with response in 75 patients with lung cancer. All these patients were treated with both anti-PD-1 and anti-CTLA-4 with responses in a subset of patients. In both panels, blue indicates the patients who derived clinical benefit from treatment, defined as complete or partial response, compared to those that did not show benefit, meaning those with stable or progressive disease. The graph on the left depicts the relationship between PD-L1 expression and the level of TMB, showing no correlation between the two markers, as well as no correlation between the markers and survival. The graph on the right shows that patients with high TMB and PD-L1 expression were more likely to respond to therapy when compared to patients who lack these two biomarkers. This data suggests that TMB and PD-L1 may be predictive markers which are imperfect alone, but may perform better when used in conjunction. Let's look at the expanding use of checkpoint inhibitors to treat different types of cancers. The rate at which checkpoint inhibitor therapy is changing oncology is impressive. Shown here are all the FDA-approved checkpoint inhibitors for solid tumors. As you can see, the first was approved for treatment of melanoma in 2011, and since that time, 28 more approvals have occurred, often with many approvals in the same year. It's difficult to overstate the impact this has on modern oncologic approaches. There has been no other time in history during which so many drugs have been approved so quickly. The diversity of cancer types that are now amenable to treatment with checkpoint inhibitors is also remarkable. Consider all the other immune oncologic therapies, such as CAR T cells, tumor vaccines, and antibody conjugates, which are also either recently approved or will be soon. It is clear that the future of oncology is intimately and inextricably intertwined with the field of immunology. To convey the scope of current clinical trials, the data shown here comes from the Cancer Research Institute, depicting the number of anti-PD-1/L1 trials being tested in combination with other therapy. Literally hundreds of trials are exploring the relationship of anti-PD-L1 therapy with other immune, chemotherapeutic, radio, and anti-VEGF therapies.
The current immuno-oncology field employs a variety of strategies to target various tumor types. This presentation is focused mainly on checkpoint inhibitors, and that's because these drugs are poised to dominate the immuno-oncology market over the next decade. It's still worth mentioning other treatment strategies also under development, such as engineered adoptive T-cell approaches, which have already shown clinical benefit. Adoptive lymphocyte therapies are the paragon of personalized medicine, as the patient his or herself provides the very cells that are ultimately engineered to fight their cancer when reintroduced into the patient's bloodstream. Other immune system modulators, such as small molecules and conjugated antibodies, also share the ultimate aim of stimulating the immune system. Cancer vaccines have similarly shown promise in recent trials as they're able to modify the patient's anti-tumor immune response. And finally, oncolytic viruses are on the horizon as we explore ways to manipulate both the host immune system and the tumoral response to therapy. And in closing, we're going to briefly touch on the biomarker landscape. As the biomarker landscape is currently less defined than the immuno-oncology strategies we've mentioned, there is significant need to develop better predictive biomarkers. The markers we currently use to make therapeutic choices, such as PD-L1 and MSI, are joined by the emergence of tumor mutational burden, as well as many other promising new biomarkers, such as multiplex immunohistochemistry, liquid biopsies, and mRNA profiles. While most of these technologies are still in their very early stages, they show significant clinical promise. In summary, the rapidly expanding field of immuno-oncology has enormous implications for the current practice of pathology. These new biomarkers and therapeutic options offer us as pathologists the opportunity to guide our clinical colleagues in order to ensure the best possible outcome for our patients.